Okay, Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, it's my pleasure to be with you today. Welcome for you all. Also, I extend my thanks to Ministry of National Guard, especially the Dean or the Deanship of Postgraduate Education. I'm Dr. Khalid Al-Dosri, Associate Professor and Consultant in Diabetes Management and Family Medicine. Joining me today, Dr. Raed Al-Dahash. He is a consultant in endocrinology, and he is a head division of the endocrine division, internal medicine department, and he is also an assistant professor, assistant clinical professor at KSAU University of Health Sciences. So today we have an interesting topic. Actually, it's a hot topic regarding COVID-19 and diabetes. We will touch some important point today. Shall the diabetic people is more prone to have the COVID-19, and if they got the infection, is that related to the mortality and morbidity? Dr. Raed will start his slides and talk in details about that, and before the end, I'll talk just about the morbidity and mortality in a few minutes. Then we'll take the question and answer sessions. Hope that you will join the session. Dr. Raed, welcome.
Thank you, Dr. Khalid, for your introduction. We will talk today about very important topics, I think. It is management of those patients COVID-19. As you know, COVID-19 is a problem nowadays, and we have a lot of patients in the hospital or as outpatients. Sometimes they call us to what to do with them if they are diabetic. So we will share with you today some of the slides and some of the talks about this disease and about how to manage those patients when they have diabetes. We will talk about, first of all, about overview about the disease. The disease, as you know, it started in China, the first case, and this was in December 2019, and it's almost 4 cases, and it's notified by Dr. Zhang. Then after that, he reported to CDC there is unusual pneumonia cases. Then after that, it came to be more and more cases starting in Wuhan city. Then after that, the cases after cases and the infection started to be spread inside Wuhan, then be transferred from Wuhan to another city. Then after that, it will be outside China, then it will be everywhere in the world. So if we try to calculate the epidemic, it starts from December 2019. That's why they call it COVID-19, based on 2019. The first name also was, it's like severe acute respiratory syndrome coronavirus 2, because we have coronavirus than this. So what's the timeline of COVID cases after onset of illness? This is, I think, very important. Those people with COVID-19 generally develop signs and symptoms, including mild respiratory symptoms, fever. It came to be 5 to 6 days after infection, but usually it's range up to 14 days. The median incubation period was 4 days, sometimes up to 7. That's why they told the patient, if you are exposed to somebody after 7 days, if you don't have symptoms, you are free. And if you have symptoms after 10 days, you cannot infect others. So if we start this journey in January 2nd, 2020, there is 41 patients admitted in the hospital, identified having laboratory confirmed COVID disease. The data was obtained with standardized data collection forms sharing by WHO and International Severe Acute Respiratory and Emerging Infection Control for electronic medical records. The data was analyzed to confirm the timeline of COVID cases after onset of illness. So usually the signs and symptoms, it's variable. Usually those came with fever is a lot in non-ICU setting. However, in ICU setting, we have to up to 26%. Those with fatigue also having in non-ICU setting up to 50%, and in ICU setting up to 20. So, and there is multiple other, other sign and symptom like anorexia, myalgia, dyspnea, diarrhea, nausea, dizziness, headache, vomiting, loss of smell, loss of taste. Sometimes it's a sign and symptom of COVID-19. It's approximately 80% of laboratory confirmed patient having mild to moderate symptom, and there is 13% having severe disease. There is 6.1, they are very critical. They having respiratory failure, septic shock, and multiple organ failures. However, there is some patients that are totally asymptomatic and they are uncleared, and we don't know exactly how much the percentage, because most of them, they don't come to the hospital and they don't complaining about anything. Most of the patients having good prognosis. However, there is few are critical condition. In elderly with chronic underlying disease, they have poor prognosis. We see it a lot. Children relatively mild to moderate symptoms. They don't, we don't see a lot of severe symptoms. If we start in this journey in March 10, there is 3,140 of out of 80,000 laboratory confirmed cases. They are died with fatality ratio 3.8. Overall, the ratio was variable from location to location. For example, in Wuhan was 4.8, but if we see outside Wuhan, it was 0.8. So we cannot judge exactly, depend on the area. For example, thanks God, in Saudi Arabia, the fatality rate is low compared with other countries. In the China, overall, the fatality rate was higher. In early stage of outbreak, it's reaching up 16%, 17%. However, it's reduced over the time to 0.7. People reporting there is no comorbid conditions. They are very low fatality rate, 0.9, but those having comorbid condition like diabetes, what we talk about today, it's increasing up to 7.3%. So what's the question come to us, all of us? What's effect on diabetes in those patients in COVID infection? Is the diabetes increasing risk of COVID infection, or COVID infection it's targeting diabetic patient, or what's the relation between both of them? This is the second point or content to be discussed today. So if we're taking overview in all the study, it's variable in those with diabetes, as I show you here, starting from this studies and continue to see the fatality rate of diabetes patient. It's almost 7.5. Sometimes it's up, sometimes it's down, depending on the number of patients and from where the study came from. There is other risk factor, as you know, cardiovascular disease, carcinoma, chronic lung disease, and other comorbidities. But I think cardiovascular disease and diabetes taking the higher share. So, if we ask ourselves another question, it's up to 10% of those coronavirus infected patients, they are with diabetes. So according to the CDC statistics, the proportion of severe or critically cases declined from 45% in early January to be 8.7 in February, and now it's less and less. The proportion of COVID-19 patients combined with diabetes at the beginning was 20%, then it came to be down a little bit. And I want to share with you also very important thing now, that those patients having died from diabetes, they have other comorbidity, but could be overestimated. So it could be statistically biased. So those patients that with diabetes, they are type 2, they're having elderly, and they're having other comorbidity like cardiovascular, hypertension, dyslipidemia, and others. So the question now came to be, how much the percentage of patients they came to be COVID-19 with comorbid disease like diabetes, or how much of them they came with non-severe disease with chronic medical illness or with diabetes. So presence of coexisting diabetes was common in those patients with COVID-19 with severe disease than among those with non-severe disease. The percentage was 16% versus 5.7. So the data was extracted regarding 1,099 patients with laboratory confirmed COVID from 552 hospitals. So the result came to be that we have a lot of patients, or have good number of patients, they have diabetes. But however, other comorbid condition was higher. This is those with severe disease. It's almost 37% with chronic medical illness. But those having severe disease, they having 16% with diabetes. So the dark blue is chronic medical illness. The bright blue is with diabetes. Again, non-severe disease, we found that 21% they are with chronic medical illness and 5.7 with diabetic patients. If we try to see the risk of reaching to composed endpoint and the disease severity among patients with COVID-19, those patients with diabetes is the bright blue here, and those patients with non-diabetes. So the severe one in diabetes was up to 34% of them. Here, if we try to see non-diabetes, it's up to 14.3. So the diabetes have role in COVID-19. So now we know that diabetes is a risk factor for mortality of COVID-19 patients. So as a research about the clinical characteristic of 82 death cases with COVID-19 find that diabetic ketoacidosis is one of the cause of mortality. So there is a large national sample study showing the mortality of patients with diabetes was significantly higher than those with non-diabetic patients. It's almost 10% versus 2.5%. So that's why the Chinese CDC declared that the patient who report to no comorbid condition have fatality rate 0.9, while the patient with comorbid condition has much higher rate, 7.3 for diabetes. WHO Joint Mission also claimed that the patient who report no comorbid condition have less fatality rate. It's 1.4%. So patient with comorbid again having higher rate, 9.2%. So if we try to see the mortality rate, here you see the diabetic patient is higher than non-diabetes. Again, the mortality rate patient reporting by China CDC, those with diabetes is higher with no non-comorbid condition. Those they don't have any disease. So again, there is a close relation between diabetes and severe viral illness in general, like SARS. As you know, the SARS is severe acute respiratory syndrome. We have it in previous years, and they found that hyperglycemia is independent predicted factor for death and mortality in those patients with SARS. Let us see H1N1. H1N1 also, they found those patients with diabetes having risk 32% if you compare it with other patient non-diabetic having 9.2%. If you see MERS-CoV that we have it in 2014, the diabetes also has a potential risk factor for developing severe disease. We see it in 2014, 2015, and 2016 in Saudi Arabia. So now, what's the mechanism? What's the potential mechanism? Diabetes may accelerate the COVID-19. So the theory came to be higher level of inflammatory cytokines expressed in diabetic patients like interleukin 6, TNF-A, alpha, and other inflammatory cytokines expressed in diabetic patient. So they are significantly promote production of TL4 inducing interleukin 6. So the study showing that coronavirus is high likely activated TLR3 and TLR4, leading to runaway immune response, which is turned to lead to interleukin 6 dominant cytokines storm, which have also been shown to be one of the leading cause of death from coronavirus pneumonia. So the interleukin 6 was associated with death with COVID-19 patient, and variable regression showing increased audit of inpatient death associated with interleukin 6. So above all, we subcalated the overestimated with TLR4 signals in diabetes may contribute to progression of the disease to severe disease and even sometimes death. This is the graph that show you how to diabetes promote death, then uncontrolled diabetes came and uncontrolled the disease, then it will be severe COVID or death. So there is another also studies talking about patient with diabetes may be having bad diabetes control after viral infection. As you know, angiotensin converting enzyme 2, it's a functional receptor of SARS-CoV. It is expressed in exocrine and endocrine tissue of the pancreas. So suggest that the COVID may cause lesion in the pancreatic islet. So it will also worsening the diabetes. Here I make it just simple for you, the cycle between diabetes and COVID. So patient with type 2 diabetes having increased grade of malignancy to COVID-19 due to immune dysfunctioning, as we share it with you, higher level of inflammatory cytokines such as interleukin 6, TNF-alpha in diabetic patient, and animal models suggest that diabetes significantly promote the production of TLR4 inducing interleukin 6. So now there is another theory that showing that viral infection could induce diabetes or leading to fluctuation in blood sugar in diabetic patient, which is adversely influence the prognosis. So viral infection like COVID, it will induce diabetes or worsening diabetes. And again, type 2 diabetes when they higher risk of COVID, and vice versa. It's like a cycle. So the virus infection can cause high blood sugar. So it's the study finding that mild patient who having not treated with the glucocorticoids still having high fasting blood sugar. There is another study also saying that there is inflammatory markers contribute to develop of diabetes by damaging the pancreatic islet. So it's like a cycle. So now let us come to our question came in the first of study. What's the treatment of COVID-19 infection in diabetic patients? So now the CDC has not been enough evidence-based medicine on COVID management in diabetic patient. There is a lot of study, but we are not sure what's the exact one. But we know that for better care and improving prognosis, we should control the diabetes in those patients. So it's like a cycle. So as you know, if the patient having irregular diet and reducing exercise and gastrointestinal symptom from the disease, it will affect the result in glucose fluctuation. Stress by the disease condition like infection, it will increase glucocorticoid secretion. Using of glucocorticoids in treating of COVID can leading to sharp increase in glucose, as you know. There are also interruption or non-standard treatment with oral anti-diabetic medication in isolation road, resulting in fluctuation of blood sugar. You know, the fearness, anxiety, tension may increase glucose level, and it might induce glucose fluctuation. COVID-19 by itself, it will produce large number of inflammatory cytokines, leading to extreme stress in some of severe and critical ill patients. So now we try inside the hospital, we make our target blood sugar for those patients mild to moderate, non-elderly. We are strict and very strict, highly controlled blood sugar. For those mild to moderate but elderly, we try to be low to moderate control. For those with severe critically ill or elderly patient or higher risk of hypoglycemia or intolerance to hypoglycemia or organ dysfunctioning or cardiovascular or cardiocerebral disease, set up of low control target. So we make it in the three category, high and medium and low. But in general talk, in hospitalized patient, usually we make them 8 to 10. As you know, most of hospitalized patients, they have comorbid condition, they have elderly, they have higher risk of hypoglycemia. So we try to make the blood sugar 8 to 10 in general. However, we accepting to our postprandial up to 14 millimole. So here we're talking about, for example, 10, it's equal to 180. It's usually just multiply it by 18. As you know, hypoglycemia is not, it's not, we don't want hypoglycemia as a doctors, and we don't the patient feeling of, sickness of hypoglycemia. They will feel that he will dying, or his will be develop hypoglycemia inside the hospital. That's why we want to prevent the hypoglycemia in hospitalized patients. So now there is a question now, how I treat my patients. What should I give? What should I stop? So we said in general, insulin treatment is a first choice in diabetic combined with the severe condition. For non-critical patient, the insulin subcutaneous injection is recommended, and basic dose can be referred to to sliding scale or to the doses of the hospital. For severely critical patient, IV insulins or IV infusions, it should be recommended. In existing serious glucose metabolism disorder with water and nucleotide acid base, also IV insulin should be performed with aggressive fluid infusion. If the clinical condition is stable and eating pattern is regular, patient can continue in oral antidiabetic medication as before admission. In general, metformin is not recommended in those severe and critically ill patient or those with GI symptoms or lack of oxygen. Metformin is not recommended. Otherwise, they can use it. Secretogenesis, mild to moderate cases using glucocorticoids. Early stage, you can choose short-acting agent because, as you know, it's short-acting, it will be affecting postprandial blood sugar. Advanced stage, we choose mild to long-acting agent if fasting and or for postprandial it's increase. Alpha glucosidase inhibitor, they can control the postprandial, but we don't recommend it for severe critical illness patient and those with gastrointestinal symptoms because, as you know, they have gastrointestinal side effects. TZDs like bioglutazones and other can be used during the process of glucocorticoid treatment. The regimen adjusts according to treatment effect. DTP4 SGL2 is not recommended at the time being. We need more study to ensure about the safety for those patients, especially in those critically ill patients. Using MPH and long-acting insulin during glucocorticoid treatment to control the glucose is very important, I think. Measure 7-point glucose is very important, and nocturnal blood glucose. So you check the fasting blood glucose to 1 2 hour postprandials, before the breakfast and 2 hour after breakfast. Before the lunch and 2 hour after lunch, before dinner and 2 hour after dinner, midnight or before sleep is very important. Also, you can check before exercise or before doing any active things. So you should check your blood sugars. So glucose management strategy, we start with mild disease. There's no necessary to adjust original regimen. Both oral and insulin treatment can be maintained. Progression of COVID-19 can be rapidly and worsening with hyperglycemia. So we are strongly recommend, even if it's mild, to increase glucose measure frequency and consult a physician to adjust those blood sugar if not reaching the target. In those having moderate disease, maintain original regimen if the patient mild condition, and if appetite and glucose control are within normal range, so maintain everything. Try to switch from oral to insulin for those start to have severe symptoms. I cannot eat regularly. Suggest switching premix insulin to basal bolus or insulin pump to flexibility of managing glucose. Those severe or critically ill in ICU, we prefer insulin IV should be first line treatment. Those patients on CRRT, continuous renal replacement therapy, the proportion of glucose and insulin in replacing solution should be increased. and decrease according to glucose monitoring result in avoid hypoglycemia and severe glucose fluctuation. So glucose management strategy for different type of diabetes in the COVID-19. We have three categories: type 1, type 2, and glycocorticoid associated diabetes. So in type 1, usually the patient either in insulin pump or in basal bolus regimen. So this is the optimal regimen. We recommend insulin analogs as a first choice. Insulin therapy regimen shall be set in accordance with principle of individuals, as you know, everybody having his choices. Type 2 diabetes, those mild COVID patient with low to moderate glucose increase, non-insulin diabetes drug can be used. Patient with fever, treating glycocorticoids, treated by glycocorticoids, insulin treatment is the first choice. Critically ill, IV is recommended. Glycocorticoid associated diabetes increase between and after lunch or before sleep. So it's important to monitor blood sugar after lunch and before dinner. So in those patients, we prefer the insulin. It will be first choice for us. So glucose management of COVID and diabetes treatment with glycocorticoids is unknown, but from our experience with glycocorticoid patient, we use it for those patients with inflammatory lung disease. Using of glycocorticoids, it might decrease the course of the disease. So the recommendation disease condition of COVID and diabetes can be changed rapidly. It's recommended to apply insulin therapy as soon as possible according to glucose level and actively adjust treatment regimen to control glucose to relatively ideal level. For fasting patient, suggest ratio of glucose to insulin in IV infusion, it's 2 to 4 gram of glucose up to 1 unit of insulin. Gradually reduce glycocorticoid usage. We should also pay attention to glucose fluctuations. So adjust insulin doses based on glucose level. So if glucose coming down and if you decrease glucose usage, so decrease the insulin, please. So it's recommended to measure 7 times glucose per day. Too much or too long course of glycocorticoid treatment are main risk factor for glucose deterioration and fluctuation. So in summary, about 10% of coronavirus infected patient with diabetes comorbidity. It seems that diabetes may not increase risk of COVID infection, but exactly promote severe progression in COVID-19 patients. Diabetes also promotes severe progression in COVID-19 patients, and diabetes comorbidity associated with significant increased mortality. Diabetes with COVID-19 appear more blood glucose fluctuation. Strength dynamic glucose monitoring is necessary. Insulin IV injection should be first line treatment in those severe critical ill patients. Thank you so much, and the mic for you, Dr. Khalid.
Thank you very much. Thank you very much, Dr. Raed, for this nice and excellent presentation. I want to talk about just a little bit about the mortality. There is some question about the mortality and diabetes. Personally, I did a review article about diabetes and an important predictor of hospitalization and mortality from COVID-19 infection. And actually, what I find in the review, in my review, a narrative review, is that individuals with diabetes are high risk of catching the infections, such as COVID-19 or even any infections like TB or others. But this risk can be decreased, as you said, Dr. Wright, by or eradicated even by maintaining optimal level of glucose control. The other thing that diabetes was seen as important predictor for morbidity and death also, as you said for one of your slides. Therefore, these patients should take an extra precaution, extra measures with good glycemic control and frequent monitoring of blood glucose. Let us summarize some important points that you said, Dr. Raid, in your presentation, that patient with mild disease, diabetic with very mild disease, usually will continue the same regimen, and usually, but we have to take care that COVID usually can make progressive severely, and we can't predict what's happening. But in moderate to severe ill patient, we have to make sure that the choices are suitable for his situation, especially that insulin is one of the good choices and important choices. Usually we are avoiding especially SGLT2 inhibitors and DPP4 in that situation. This is what we have today in our session. If we have question and answer, sessions. Do we have questions? Hello?
They send it to the text message, Doctor. They will send it to the text message.
Okay. You are welcome to write any question.
You can check Dr. Khalid the chat. They will put it in the chat now.
Yeah. I couldn't see any message. Dr. Raid, if you can see, because the screen can't show me any question.
I think they are uploading now. They will
Okay.
they will put it. Just give a few seconds.
So, Dr. Raid, what's your opinion about the other part of diabetes that's so many patients missing their appointment? They're afraid from catching the infection from the hospitals. What do you think about the glycemic control in these patients? What's your opinion about telecommunication nowadays?
Yeah, thank you so much for this question. I think it's very important question. Actually, you know, the telemedicine now, it's the key. It's not only the key for diabetic patient. It's a key management can be used. In the coronavirus epidemic and later on. So the virtual or telemedicine and the virtual medicine, it will be the future. Second thing, I recommend all diabetic patients, please don't come to the hospital unless necessarily. Please make sure you have a lot of medication, enough for you 2 to 3 months, and try to do your blood sugar frequently at your home. Try to do the general measures, like put a mask always if you go outside the home, wash your hand frequently, or wear gloves if you are in supermarkets and outside your home. The good thing that the studies don't show there is type 1 diabetes is higher risk. So the studies showing that those patients that are at higher risk is type 2 diabetes with other comorbidity. So there is one question here. It came to be, I see it in the chat. They said, I'm working in ICU as a clinical pharmacist. We are using a sliding scale with or without glargine, even with evaluated blood sugar for critically ill patients. Despite of high these readings are, or to less extent, we using infusion for logistic issue and to minimize the staff exposure, as infusion required more often monitoring of an hour or 2 hours. So what do you suggest for those cases? Thank you so much for this question. Actually, this question is very important. As I said in my lectures, in ICU patient, we recommend IV insulin infusion. As you know, if the patient on IV insulin infusion, no need to put those patients in basal insulin at the same time, unless you want to stop the infusion. So you should put the patient in basal insulins and overlap the blood sugar overlap subcut insulin with IV infusion for 1 to 2 hours to prevent increase of blood sugar for those patients, or if the patient of in DKA to prevent reappear of DKA for those patients. Please, if you have any other question, put it in the chat box so we can ask it, or we will conclude with Dr. Khalid.
Actually, I discussed with the right earlier about that point. We have some patients asking us, they phone us, doctor, I have blood sugar of 600 to 500. So what please give me anything to reduce it. Definitely, he needs to go to ER because they have to check the ketones, they have to check anything to avoid DKA. So if you are in need to go to ER, please go without any doubt. So mild cases, yes. And if A1C is controlled, no need to come to the hospital. But if you have frequent high and even lows of the blood sugar, you have to visit your doctors and contact him urgently.
Yeah. There is a question here. They said, what is, I mean, we understand from this lecture that any patient with diabetes, that he will develop, I mean, any patient with diabetes, he will be at higher risk of COVID. No, we don't say that, but we said any patient with diabetes, it's higher risk of complication to having morbidity and mortality of the diabetes. But the exposure to diabetes, it will be same for diabetic patient or non-diabetes. The risk of transmission, it will be the same, because if you expose yourself to patient with COVID-19, you will get it either you have diabetes or not. But if you're having diabetes or other comorbid conditions, the diabetes, the mortality and morbidity, it will be more.
Let us make it very easy at this point. Actually, there is a lot of debate about that, but I agree with Dr. Raid that it's 2 points. Patient with diabetes is like others for the immunity about COVID or the risk of getting the COVID. But if they got COVID, they might develop serious condition, might went to more morbidity and mortality compared to others.
Yeah. Agree with you, Dr. Khalid. There is a question also here talking about fatality rate of diabetes, fatality rate of COVID-19 with diabetic patient. We say the data we have till now, the fatality rate is 7.3%. There is other question. They said, did you think treating COVID-19 patient with vitamin D can help? The study till now, there is no correlation between vitamin D and COVID-19. They said if COVID-19 can induce diabetes, so that means non-diabetic patient can develop diabetes because of COVID-19. No, but we said that COVID-19 can send inflammatory marker and do some destruction of pancreas, so making fluctuation of blood sugar.
Actually, yeah, there is no evidence of vitamin D, zinc, vitamin C. No problem to take it. It will not make harm, but there is no evidence, strong evidence for that. And I remember that, Dr. Raid, we have a case of a National Guard that patient developed the acute pancreatitis and DKA. We don't know is that, and COVID also at the same time. We don't know is it from the COVID itself or that one make he's prone to COVID. We don't know. So that's make the COVID-19 is unpredictable to everybody.
Yeah, there is other question now. They said, should anti-diabetic medication to be reconsidered among COVID-19 pandemic? No, we said anti-diabetic medication, it will be continue like before. But if the patient is mild to moderate, we should use it easily. If it's moderate to severe, we will consider to add for those patients to add insulins, especially as you know, there is the course of treatment of coronavirus is glucocorticoids to decrease the chest problems. So those patients will develop postprandial blood sugar. We recommend for them to take insulins.
And also for the, it's not for COVID. It's not something new. For example, patients with acute MI, some cardiologists, some diabetologists, they are not starting metformin at the same time. So any acute phases or acute infection, there is some medication, anti-diabetic medication, not be used in that stage. So as Dr. Wright said, it's according to the stages of COVID. Is it mild, moderate, or severe? And still the insulin is the best choice for moderate to ill patient. Do you have any more question?
Yes, they said here. Yeah, they said why the ICP telling there is no need to re-swab patient after 14 days of isolation. Actually, this is not my specialty, but I know the answer. Nowadays, there is a study talking about after 10 days of infected with COVID-19, you will not infect the others. So what's the benefit to take another swab after 10 days? That's why they don't do like before after 14 days.
And the bed situation these days in anywhere is important, so you have to leave some beds for others.
The other question is also, it's not my specialty, but can I answer? They said, okay, it's screening, or still we should screen? Yes, the high risk patient, when they admit with either COVID-19 or other problems, we should screen them, either having symptoms or they don't have symptoms. We should screen them. Those people exposure to higher risk patients, also we should, those with COVID-19, they exposed to COVID-19 patients or COVID-19 laboratory confirmed COVID, we should screen them for COVID-19, but not for everybody and anybody.
Again and again, what you will do for your patient as a doctor or pharmacist or nurse, try to make or to do your best to control his blood sugar. That definitely will increase his immunity and decrease the complication if he got infection. I think this is what, and plus the take the measures of not getting the infections, like hand wash, proper hand wash, wearing a mask all the times. These measures is very important aspects in diabetes management with coronaviruses.
Okay. Now, other question, they said in those patients with COVID-19, they need extra insulin units or rearrangement of their treatment to manage diabetes. The answer of this, no. Continue in your regimen, or continue to put your patient in the same regimen, but you might increase the doses if the blood sugar is still high, above the targets. They said if I am the risk of healthcare worker with diabetes to deal with COVID patient, the risk of healthcare provider, either they have diabetes or non-diabetes, as a risk of transmission, it will be the same. They said, should we also discontinue ACE inhibitors or TZDs? The TZDs we know, the TZDs, we said the TZDs, we don't stop it. There is no any data said we should stop TZDs in coronavirus patients. Regarding ACE inhibitor, there is study here and there talking about this, but till now there is no recommendation to stop those medications. So there is another question. Also, it's not in my specialty, but there I can answer how to monitor the critical ill patient if they need need social distance. If you want to limit the physical contact with COVID patient, as you know, as a health worker, we should wear N95 mask or other mask to prevent the transmission of the coronavirus. It's not like the usual mask for the others. The other question here, does the people with diabetes have higher chance of experience serious complication for COVID-19? Yes, this is what we present. And yeah. They said if the patient in insulin infusion need to check blood sugar every 2 hours, patient in insulin infusion, we need to check blood sugar every 1 hour. So 1 to 2 hours is this is the recommended blood sugar measurement. I think there is no more questions, so the mic for you, Dr. Khalid.
Thank you very much, Dr. Rai. Thank you for organizing staff that they are helping us from earlier days. I think this is one of the important topics to be discussed nowadays. Hope all of you that to get healthy, please be careful and make the distance, wear mask all the time. Hope for you and all of your families all the best and continuous health. And see you soon in another webinar, inshallah. Thank you very much.
Thank you, Dr. Khalid, for sharing the sessions. Thank you so much.
Yeah, sorry for this. It just says that they disconnected from internet. So we reached to the administrative control. I think this is what you hear last. And the most important thing here, as we said, that the dentist and the healthcare worker, the dental clinic need to wear the face mask all the time. We have to limit clinical care to be one patient at a time. As I said before, priorities for urgency and urgent thing need to be also looked at. Avoid result generating procedure, but in case if there is any result generating procedure, we have to advise for four-handed dentistry. So another guy will help during this, and we have to use a high evacuation suction and also use the dam. And this all, the dental dams, this all will decrease, you know, the aerosols. The other thing also we need to consider the pre-procedures mouth rinsing. Some engineering control, most of this engineering control related to using HEPA filters, either portable, using the high, changing the HVAC system to have a negative or semi-negative, even if it's not, you know, negative pressure room, but at least negative ventilation. So most of the air and the air change per hour it will be increased. I know it will be difficult to change all our, you know, dental clinic to have it as a negative pressure room, but at least if it's not, you know, a negative pressure room, and we cannot do it, at least at a negative ventilation, or to use a portable HEPA filter near to the patient head during the dental procedure. The personal protective equipment, we advise for surgical mask, eye protection and face shield, and also the gown with protective clothing during procedures, especially if there is any splashes. And during AGPs or aerosol generating procedures, using the N95 respirator or copper, which is the positive airway, hoods and that, you know, protect those who are not, you know, fit tested. Some of the environmental infection control, and this is also as a general rule, is not something new. Some facilities, they have more than one chair at that place. Let's say this is an open area with many dental chairs, and this is actually, I don't think in our area we have them. Usually the dental chairs, they are assigned to one room, so each room have one dental chair. But if there is an open area where we have a lot of dental chairs at that area, we have to maintain 6 feet, you know, spacing among them. And this is very also important environmental, you know, control steps. Other, you know, all related environmental infection control is mainly dedicated to disinfecting and the high touchable areas, the chairs, the room, and also the things that we are using instruments, and also to give, you know, a good time between patients, not less than 15 minutes, to ensure that the air change per hour or the room air change, and also ensure that we give the staff appropriate time to do the cleaning of the room and all the equipment. Sterilization and disinfection of patients' care items. This already mentioned by my colleague Hisham. There is no specific changes. It's the usual protocol when we are dealing with respiratory pathogens. We need to look to every area inside the room, especially the high touchable area. With that, I reach to my end of my talk, and mainly what we covered here with the dental clinic precautions. We need to be sure that the staff, they are aware about their risk, and also they know how to use the PPEs, and the PPEs, they are available. Doing the triaging, having the patient on time, and trying to minimize using the waiting area. The waiting area need to be prepared to have good spacing, and also without any magazines or toys or anything there. And whenever we have any result generating procedures during the procedure itself, we have to depend on other equipments, other people to help us to minimize and to be away from the head. The negative pressure rooms, we cannot maintain it inside the dental clinic, but at least negative ventilation if it's possible, or to have a portable HEPA filter. Other related, environmental health or environmental infection control, it's just a routine, but generally speaking, we have to give a good time between patients to give the enough period for cleaning and disinfections, and also for the room to air to be changed between patients. This is the end of my talk, and I'm sorry about what happened. I hope it was very helpful. Thank you very much. I'll just trying to take this out. This out. So this is the end of our session for today, but we'll go before that to I'm trying actually to connect our colleague from the GCC Health Council. I don't know if they are able to come with us or not. Are they aware? Are they around? Our colleague from GCC Health Council?
No, doctor, they could not log in.
They couldn't? Okay, so we'll take maybe one or two questions, then we'll close if there is any other important thing. So some of the questions here from mainly, I think, towards medications, some of them regarding medications. So maybe this for Dr. Noor. Dr. Noor, are you around?
Yes, Dr. Majid, I'm here.
Yeah, so here we're talking about the recovery trial. Did you use any other steroid other than dexamethasone?
I believe they used, I think there was a small number of pregnant patients, I think like less than 10 patients where they, obviously they wouldn't use dex, they used prednisone. I think that was the only one. And it depends on what part of the recovery trial they're talking about. So if this is the dexamethasone arm, then they only use dexamethasone. And in general, I believe even in the hydroxychloroquine arm, they only, if they did end up using in the follow-up period steroids, it was mostly dexamethasone.
Okay, but there is a small group that use different than dexamethasone, but they are very minimal, and that's recovery trial. They're not a lot. But when you look to the recommendation, they are okay about to use any steroid with equivalent, dosing, equivalent dosing to 6 milligram of dexamethasone.
Okay.
Am I right?
If the question is if can you use other steroids if not available, I would say yes. I mean, of course, the dexamethasone has mineral corticoid. It's a bit different, but yes, I would use other steroids if not available.
Yeah. Another questions about, maybe I'll answer that. If they are looking to, whenever we have cytokine storm, we will give, some medication like tocilizumab and others, and also using dexamethasone as anti-inflammatory also to suppress the immune system. And how that come when we have a patient with cancer and they are on these medications, they will have bad disease. So why when we have the infections and we treat them with what we know that will dip the immune system lower? And I think this is what I understand from the question. There's something called the net immunosuppressive state. So a human body, they have different mechanism of immunities, and when you look to the transplant patient, cancer patients, they have more than just medication-related immunosuppression. They have others. They are already from the underlying disease. They are immune suppressed, and that's why the problem of when we give them on this medication, they will be more immune suppressed because the underlying disease, and then when they have the disease or the infection, they will have maybe bad outcome. So there is something called the net state of immunosuppressions, and this is the thing that causing the issue. Then a question about using ceftriaxone in COVID-19 cases, maybe for you, this Dr. Noor.
I mean, if the patient, So the question on antibiotic use in COVID patient is valid. You have a patient with a viral infection and you theoretically are concerned about a superimposed bacterial infection. So what's being done right now is everybody receives this bulk ceftriaxone plus or minus atypical coverage. And I think that if the patient is severe enough to, and you're not able to clearly rule out bacterial infection, so in severe ICU admission, you could consider giving ceftriaxone or other antibiotics for the first 1 or 2 or 3 days even. But if it's clearly COVID and the patient does not grow anything on cultures, and it's important to take cultures, and procalcitonin is not, even though it's not a very, very good indicator, if procalcitonin is not going really with bacterial infection, I think I would suggest considering discontinuation early. Does that answer the question, Dr. Majid? I didn't see.
I think it's answered, but they are looking to
choice.
No, they are looking to do we need to treat acute pneumonia, viral pneumonia due to COVID-19 with antibiotics? Do we treat them as community-acquired pneumonia with ceftriaxone alone or other agent?
So there is a recent study that looked at COVID versus H1N1 and early onset co-bacterial infection in these two patient populations, and they found that early onset bacterial co-infection is unlikely. So early onset was defined in the study by 7 days. So the study was kind of reinforces that you need to really choose your patients that require antibiotics in the first 7 days if they're not a severe hospitalized ICU patient. That would be my recommendation, to be very vigilant on who to use ceftriaxone or other antibiotics with initially.
Sure. Thank you. So there is a question about any differences between collecting nasopharyngeal versus oropharyngeal sample. Is Dr. Samira still with us? Dr. Samira?
I don't think. Okay,
so I'll take that question. Generally speaking, the recommendation for most of respiratory viruses sampling that better to take a deep secretion as much as we can. If it's not, and after that it will be using nasopharyngeal or oropharyngeal sampling. Some of the kits, they have the two samplers together, the oropharyngeal and nasopharyngeal in the same kit or VTM. So we'll do both of them together. So nasopharyngeal, oropharyngeal on the same patient. We put the two probe on the same VTM or viral transmitted media and send it to the lab. And this also, the yield will be much better. So first deep secretion, then to use both of them in one VTM, which is the second to that. The third, it will be nasopharyngeal. So if I was asked to do which one, if I have one probe, I will use nasopharyngeal rather than oropharyngeal, and the difference is around 30%. I hope that will answer your question. There is another questions about Assalamu alaikum. Patient testing positive, all necessary measures done, then re-swab results negative for a few days, then tested again, become positive. What is your opinion with regards to the management of this patient? Dr. Asim? I think he's not around. Anyway, so I will answer that question. So generally speaking, we depends on time, we depends on symptoms rather than swab for recovery. So the risk of transmission of the disease, it mainly depends on the time elapsed after symptoms recovered, or from the onset of the symptom till the symptoms recovered. Generally speaking, most of the study, they're looking to 10 days from starting symptoms, at least 3 days of no symptoms, regardless of the swab results. Okay, so we need to take this equation of the swab result out. More evidence coming to shorten this duration. So the recent trials is looking to 6 days from the onset of the symptoms and at least 1 day without symptoms, regardless of the swab result, regardless of either negative or positive. But these patients considered to be recovered, and if they are recovered, the risk of transmissions, it's almost nil. But with that, I think we reached with our the end of this webinar. I would like to thank the speakers for reaching this webinar, and also I would like to thank you all of be patients with us. And at the end, I will just need to apologize for any inconvenience. Thank you very much. Thank you all. Assalamu alaikum wa rahmatullah.
Thank you, Dr. Martin.
Thank you.